Hello and welcome to Introduction to Ultrasound. This is a prelude to your practical session. I want to talk to you about our objectives for this lecture. I'm going to talk to you guys about general terminology for ultrasound. I'm going to show you some specific ultrasound anatomy and tell you about some of the clinical uses for ultrasound. So when you think about what an ultrasound looks like, maybe you have this come to mind. It's not actually what you're going to be looking at. So essentially, ultrasound is sound waves, and sound waves transmit through tissue and basically are recorded on the other side by the transducer. So the transducer is the piece of equipment that sends the sound wave through the tissue, and it not only acts as the microphone, but it also acts as the receiver. I want to try to keep things pretty simple and focused for you guys. And when we're talking about ultrasound, we talk about a couple of different things. You've got frequency, attenuation, reflection, and amplitude. And I'm sure you guys remember all of this stuff from your physics days, so we're going to go over them fairly quickly. So as you may recall, frequency is cycles per second, and attenuation is basically how the ultrasound changes or behaves as it goes through different layers of tissue. Reflection is sound waves basically being transmitted back to the probe, and amplitude is basically how powerful the ultrasound actually is as it's going into your patient's body. So exactly how does this work? We've got these things called piezoelectric crystals, and they're in the end of the ultrasound probe itself. And there's an electrical signal that is applied to these crystals, and then when the crystals deform, they create a mechanical wave. That mechanical wave is interpreted as sound waves, and it goes through the patient's body. The probe sends that sound out, and then as the sound bounces off the patient's tissues, it comes back to the probe and then is interpreted into an image. So as far as how we figure out what we're looking at, one of the things that's important to keep in mind is the frequency, which is, again, how many cycles per second the sound waves are transmitting through the body. And the frequency is going to be determined by which probe you're using. What you guys will see is a bunch of different probes on the right-hand side. The top left probe is called the curvilinear probe, and this is a low-frequency probe. Now, low-frequency probes are designed to go very deeply into the patient's body, and they're not going to give you a whole lot of resolution as far as the picture quality. The superficial probe, or the high-frequency probe, is much higher frequency and much more detail. It'll make a lot more sense when I actually get you guys practicing. Attenuation is basically what happens to the probe itself as it is, or what happens to the sound wave as it's going into the patient's body. So the farther it goes into the body, the more the signal degrades, and this is a piece of, the physics, again, that has to do with some of it reflecting off of tissues, some of it sort of degrading as it goes into the tissues, and so that's going to impact your overall signal. The other thing is, because this is energy, it's going to be absorbed by the body, and so you won't get all of the sound waves back towards your probe. When it comes to reflection, you're going to get different layers of reflection depending on how dense the tissue is. The more dense the tissue, so in the body we're looking at things like bone and calcifications inside a blood vessel or gallstones, those are highly calcified things. They're very dense, so they're going to reflect most of the sound waves back towards them. Low density things like water, basically urine in the bladder, or bile in the gallbladder, or blood in the blood vessels is pretty low frequency, so it's going to transmit waves very well. When it comes to basically your amplitude or the power of the wave, this is basically what offers potential for injury. And so the higher the amplitude or more power coming out of your ultrasound probe, the more heat is released. And although this is not as big of a deal in the emergency department because we don't actually use ultrasound for therapeutic tissue reformation, when we're doing ultrasounds on babies, we want to make sure that we're using a lower frequency. Some terminology that you guys are going to need to kind of get used to. Hyperechoic means that there are a lot of echoes, and on ultrasound that means it's going to be much brighter white. Hypoechoic means there's less reflection, and so it's going to be more of a gray scale. Anechoic means without echo, so this is going to be your blood vessels, your gallbladder, your bladder, because they're basically fluid filled. Shadowing is a term that refers to the loss of ultrasound transmission. So there's basically absence of ultrasound transmission. So you're going to see shadowing behind calcified structures like bone and gallstones and any calcifications in blood vessels. The other thing you guys should know about is something called an acoustic window. And an acoustic window is essentially a space through which you can actually transmit ultrasound waves. So here's an example of something that's hyperechoic, and I'm going to highlight it here. And that's basically brighter white than the tissue around it. Then we'll talk about hypoechoic. Again, I'm going to highlight the area that's hypoechoic. So this is darker than the tissue around it. And then we'll go to anechoic, which is your bladder in this picture, and going to sort of highlight it there. So this has no echoes, so it's black, and that's what that looks like. As far as what shadowing looks like, so this is a picture of a gallbladder, and it actually has a stone in it. So you can see the bright white or hyperechoic rim of the gallstone, and then behind the stone itself you see less transmission of sound waves, so there's the shadow. Here's another example of shadowing. This is more of a superficial shadow, and this is basically the ribs. And this is using a superficial probe, and so the sound waves are basically bouncing off the ribs and coming back, so you have an absence of transmission of sound waves behind that. So just take a quick look at this, and I just want you guys to pay attention to how you would describe each of these different areas. So when you look at area number 1 and you compare it to the area that has the asterisk, the area that has the asterisk is actually the patient's liver, okay? And the stuff that is kind of gray, almost the same shade as the liver, that's actually what we call sludge inside the gallbladder. So sludge in this case is isoechoic or hypoechoic with relation to the liver. If you look at number 2 is bright white, and so that's more hyperechoic, and this is just some bowel gas over in that area. Number 3 is a shadow, and that shadow is behind the bowel gas. And then number 4 is another example of anechoic or without echo. Okay. So this is one example of an acoustic window. This is the bladder. So the bladder is often filled with urine, and so it's very easy to transmit sound waves through. And then this is another example of an acoustic window. This is the right upper quadrant. To the left of the screen you see the patient's liver, and then to the right, sort of that football-shaped structure, that's actually a kidney. And because the liver is a very fluid-rich organ, it's fairly easy to see through. Some things that you guys will need to do when you're actually using the ultrasound is modify what are called the depth and the gain. You want the structure of interest to take up basically 2/3 to 3/4 of your screen, and you want the gain or the volume of the ultrasound picture to be optimized, so it's not too bright and not too dark. When it comes to holding the probe, you want to hold it like this. Sometimes say hold it like a pencil, but everyone holds their pencil a little bit differently. So basically hold a thumb on one side and 2 fingers on the other side, and then use the back of your hand to sort of stabilize yourself. These are our ultrasound machines. This machine is the Sonocyte, and this is one of the machines that we use in the emergency department. And then we also have a machine called the Zonari. And this is just to kind of give you guys a view of what they look like. As far as how the buttons work, there's your depth adjustment here on the Sonocyte, and your depth adjustment is here on the Zonari. And then your gain, or the ultrasound volume, is here on the left with your Sonocyte, and it's on the right with your Zonari. When it comes to choosing the the probe that you want and actually getting the image of the structure that you want, you first need to make sure that you're using the right probe. So if you're doing something superficial, you're going to be using the high frequency probe. If you're doing something deep, you're going to do the low frequency probe. You want to make sure that you're oriented appropriately to the screen, and we'll talk a little bit about that in a minute. When you move the probe, there are certain movements, and then optimizing your image has to do again with making sure you have the depth set appropriately and that your gain is set appropriately. This is an example of the linear transducer, and this is what a blood vessel looks like in long axis on the screen. And so if you look on the right picture, there's a little blue dot, and that corresponds to the actual, what we call probe marker on the ultrasound itself. So the probe marker is also the little dot on the left picture here. And then this is an example of what a curvilinear image will look like. And again, the image on the right-hand side, there's a GE on the upper left-hand side, and that's towards the patient's head, and that corresponds to the dot that's kind of difficult to see in this image. This is, again, an image of the ultrasound probe itself with the indicator mark there, and then the surface of the probe is actually what touches the patient. As far as which way you're going to orient yourself when you're doing ultrasounds, your general abdominal exams, your probe marker is going to be either towards the patient's right for transverse views of things or towards the patient's head for longitudinal views of things. For musculoskeletal imaging, it's basically the same thing. These are just some anatomic planes, which may not be as pertinent for you guys, but it'll kind of help you understand the terminology that the docs are going to be using in the ER. So the sagittal plane basically cuts the patient front to back, so basically from their nose to their tail. The coronal plane basically cuts along the mid part of the patient, basically from their armpit, one armpit to the other armpit. And then the transverse plane is just a straight front to back, almost as if the patient was a sandwich. What this looks like on the screen is when you're doing the transverse view, the probe is going to be side to side on the patient's belly. The probe marker is going to be to the patient's right. So what you're looking at on the screen, the right of the patient is going to be on the left of the screen. The left of the patient is going to be on the right side of the screen. And the skin or the anterior surface of the patient's body is up at the top of the screen, and then however deep your probe is set is going to be the posterior of the screen. In the longitudinal plane, this is again, the probe is on the patient, but the probe markers aim towards the head, so the probe's kind of straight up and down. And in this situation, anterior and posterior are still the same. Anterior part of the patient is still the top of the screen, and the posterior part of the patient is still the bottom of the screen. And then the patient's head is going to be on the left side of the screen, feet on the right side of the screen. Now, there are a couple of specific movements that you can do with ultrasound, and these basically allow you to change what you're looking at, because you can only really see what you're aiming at with the ultrasound probe. So the probe movements are fanning, and that's just as if you're really hot and you're just using your hand, just fanning. Imagine your thumb is actually the probe marker. Then there's rocking, which is like you're in a rocking chair, rotating, and then sliding. So we kind of talked about this already, so I'm not going to talk too much more about this. I want to sort of move into some pictures, which might be helpful for you. And this is what bone looks like. So that very bright white line that's right here kind of looks like an upside down U or upside down V. That's a bone, and that's in the transverse plane. And the picture on the right is the bone in long axis. And then we've got some pictures of muscles in long axis. You can actually see the striations of the muscular tissue, and then the muscle in transverse plane on the right-hand side. And if you imagine this was red and white as opposed to black and white, it would kind of look like a steak. A tendon, also, basically different shades of gray, but tendons themselves have what we call a fibrillar pattern, so it almost looks like a barcode sign. So the arrow in the middle, the triceps tendon, is actually pointing to the triceps tendon. Cartilage is a very fluid-rich substance, so it's going to look very black. This is basically just a line of cartilage on the distal femur. These are some blood vessels in action. So this is basically just the sonographer is compressing the blood vessels. You see that one of the blood vessels stays nice and plump. That's because that's actually an artery, so the wall is much thicker and it does not compress. And then just above and to the right of that artery is something that looks kind of like a honeycomb. That's actually a nerve. And then here's another example of a nerve. This is in the middle of the forearm. This is the median nerve. It's right there in the middle of the screen. And then, folks can actually have fluid in their joints. And so this is just an example of what fluid in a joint would look like. Again, fluid is black or anechoic. On the right-hand side is basically a fluid collection from an infection. So this would be like a boil or an abscess. You guys may be wondering what else you can look at. You may have some ideas. There's, of course, pregnancy. You can look at babies. And then you can also look at the heart. This is an example of a very yucky gallbladder that actually got taken out. And this is just a little something funny for you to think about. Additionally, patients will come in with swollen legs, and so oftentimes we'll actually look for what is called a deep vein thrombosis. We can also look at patients' lungs to check for collapsed lungs or check for pneumonia or check for fluid around the lungs. So when it comes to actually using ultrasound in the emergency department, it's a little bit different from radiology ultrasound because radiology ultrasound is designed to look at a comprehensive sort of assessment of a particular body part. Now for us, we're really trying to answer very specific questions. So the 6 major areas that we normally focus on are these listed here, and I'm going to go into a little bit more about each of them. A FAST exam, or a focused abdominal sonography in trauma, is actually done in trauma patients looking for signs of severe intra-abdominal bleeding. Echocardiography is another fancy word for ultrasound of the heart, and so we're looking for problems with the heart, fluid around the heart, or poor contractility or poor heart function, and also signs that one side of the heart is swollen compared to the other. We can also look at the gallbladder, babies, the aorta, which is the main blood vessel in the body. And again, like I mentioned before, looking for a deep vein thrombosis. So let's just move right into the FAST. I mentioned that we use this in trauma patients. We can also use it in patients that have low blood pressure, and we're not entirely sure why. And so let's just talk a little bit about that. So we're looking for blood in the belly. You're also looking for blood around the heart. You can look for blood in the lung, which is the hemothorax, and you can also look for a pneumothorax, which is just a collapsed lung where there's air surrounding it. We've got 4 different views: the right upper quadrant, subxiphoid, left upper quadrant, and pelvic. And when it comes to the right upper quadrant, you will probably, like, if you guys feel the bottom part of your sternum, right where your ribs meet, that's called your subxiphoid. And if you drew an imaginary horizontal line from side to side and you intersected that with what's called the mid-axillary line, so basically your middle of your armpit intersecting with the horizontal subxiphoid line, and you put the probe marker towards the patient's head, you stick it on the patient's body, that's basically where you need to look. And essentially what we're looking for here is there fluid in what is called Morrison's pouch, which is the hepatorenal recess, or is there fluid above the diaphragm? So this is what a normal FAST exam looks like. In the first part of this image, you see a bright white sort of curvy line on the left-hand side of the screen, then you see a big gray organ, and then you see a kidney. And there's no fluid in this picture. And then we've got this picture where we've actually got quite a bit of fluid. Remember, fluid is anechoic, so it's that stuff on the right-hand side of the screen. Fluid tends to follow the curves of the bowel and the curves around the solid organs. Here's an example of some fluid in the lung. So this bright white line here is the diaphragm, and then that black sort of triangular looking thing is some fluid in the lung. The subxiphoid is a way of looking at the heart, and so that same spot where you used for your reference, that's basically where you're going to look for the heart. So you put your probe in there and you aim up towards the left shoulder. The probe marker is going to be to the patient's right, and you're essentially looking for this. So this is someone's beating heart, and there's no fluid around this heart. And then looking at a different view of the heart, there's actually a tiny amount of fluid on the back side of the heart, just that little black stripe. This is the left upper quadrant, so this is going to be looking at your splenorenal recess, and this is that same sort of orientation. You look at the horizontal subxiphoid line and you go laterally and intersect with what's called the posterior axillary line, so the back of the armpit, and put your probe on the patient's body, and then you can see this. And again, we're looking for fluid in this area. And here's an example of normal. And then this is an abnormal. So you can see kind of the tail of the spleen hanging out over here, and then there's some black fluid around it. Here's another example of an abnormal left upper quadrant. This has some clotted blood and some fluid on top of it. Then we go to the pelvic view, and this is just above the symphysis pubis, or right above the bladder. And this is what free fluid in that area would look like. So the big sort of circle on the right-hand side of the screen is the bladder, and then those little black sort of triangles and stripes to the left-hand side are free fluid. Now when it comes to echocardiogram, or the heart ultrasound, I mentioned earlier we're looking for fluid around the heart, which is a pericardial effusion. We're looking for general contractility, which is basically how well the heart is squeezing. And then we're looking for what's called right ventricular dilation, which can be indicative of a massive blood clot in the lungs. And then there's some other things we can look at as well. And there are 4 main views of the echocardiogram. And so the parasternal long axis view is this one here. And essentially, the probe is going to be right next to the sternum. And your probe marker on this one, contrary to what I told you earlier, echocardiogram is a little bit different. So with a parasternal long axis view, the probe marker is going to be down towards the patient's left hip. It's going to be aimed towards the apex of the heart. And when that's the case, what you see on the screen is right there in the middle, you have kind of an anatomic representation of what you're seeing. The top part of that view is the right ventricle, then the next part is the septum, and then the next part is the left ventricle, and then aortic outflow tract. And hopefully we'll get some examples when we have you guys in our practical session. The parasternal short axis is basically the reverse of the parasternal long axis. So this one's going to have the probe marker down towards the patient's right, and you're taking basically a donut view through the left and right ventricles. This is a really good view for looking at general contractility or squeeze of the heart. The next one after this is your apical 4-chamber view. And in this one, the probe marker is actually still towards the right hip, but the probe is touching the patient's chest wall right at the bottom of the heart, or what's called the point of maximal index. And this allows us to see all 4 chambers of the heart at the same time. This also allows us to compare the left to the right very well, and this is really where we're looking for what's called right ventricular dilation. This is that subxiphoid view that you guys already saw once in the FAST exam. Again, this is a version of a 4-chamber view of the heart, looking from the bottom. And so if we found any fluid around the heart, it would actually be, interestingly, at the top of the screen, because the top of the screen is actually the bottom of the patient's heart. So that's just a little bit of an introduction for you guys on, some of the things that we use ultrasound for in the emergency department. I'm looking forward to doing a practical session with you so you guys can actually get your hands on the ultrasounds themselves and kind of get a framework for how this works for us. I'll see you soon.